All right. Thank you everyone for joining us today for one of our breakout sessions. My name is Priyanka Surio, and I am the Director for Data Analytics and Public Health Informatics at ASTHO, and I'm pleased to be today's moderator for the Trace, Notify, and Investigate How Tech Aids Time-Tested Disease Investigation Methods breakout session. Each participant has entered the breakout on mute. As noted in our chat, there will be a Q&A function featured during the latter part of our session to ask questions of our panelists. And also, we ask that you keep your line muted and that you don't engage or ask questions outside of that. If you would like to submit a question or a comment to the group, again, you'll have an opportunity to do that later on in the session. If you'd like to leave the breakout session and join another one, you can click the leave button at any point on the control bar at the bottom of the Zoom window. And when you click on that button, you'll have the option to leave the room or leave the meeting. If you leave the breakout room, you will return to the main room. And from there, you can click out another breakout room in your control bar and hover over the breakout room you wish to join. The technical host will be around to help if you have any difficulties. And this breakout session is being recorded. So just to begin and to provide some context for today's session, again, we'll be talking about how multiple organizations, particularly those who our panelists represent, have worked to cultivate innovation in the areas of case investigation, contact tracing, and exposure notification. In this session, we'll hear from these experts that have supported or directed these efforts to develop applications and tools in this space. We'll learn from their experience and also have an opportunity to share your own questions or experiences during that Q&A portion. So without further ado, I'm actually going to go ahead and have us watch some of their pre-recorded videos and presentations in this way, and then we'll dive into the discussion afterwards. So if we could cue up the first video, please.
Hi everybody, my name is Jenny Wanger and I'm with the Linux Foundation Public Health. And I'm going to talk about the history of exposure notification. But really what I'm going to talk about is how you get a wide variety of communities together, including government, big tech, nonprofit, and startups, to work together on a technology that has never been deployed anywhere in the world before, to get a product launched from idea to finish in under 3 months. And it's now on the phones of over 150 million people globally. So let's go back a year, right? This idea of doing digital contact tracing was just emerging. Singapore had launched a system to do this via Bluetooth, and there were debates about whether the system should be centralized, what it should be able to do, whether GPS should be involved, what the goals of the system were. There was a lot of discussion about whether this was a technology that would be supplementing or replacing contact tracing. There were so many questions, and there were technical challenges as well, right? Some of which we were starting to realize would seriously hamper our ability to be successful unless we were able to convince Apple and Google to change how they used Bluetooth at the operating system level. And so with all of these headwinds, we had dozens of companies, governments, and nonprofits engaged in this space. There were a variety of different protocols being developed, and there was a huge concern about interoperability because with so many different people working on this technology, we ran the risk that none of these solutions work together and the power of the system, which relies on high adoption rates, would be wiped away. So this was about the time where I met up with a couple of other key players in the space to co-found a group called the TCN Coalition. It was technologists, companies, and public health authorities who agreed that everyone could build their own apps with their own use cases and ideas, but using the same underlying protocols so we could have interoperability between solutions. We put some very clear lines in the sand about what we stood for: privacy, transparency, and effectiveness. We were open source and held that up as the highest standard in this space. And we advocated that the only way that this technology would be trusted by the public was if it really respected a user's right to privacy. Meanwhile, Apple and Google told us that they wouldn't change their operating system to make our protocol work, but that they would instead create the exposure notification APIs that our members could build on. And this really started to change things, right? And we started to see some apps launched in Europe, which everyone celebrated. As we saw more and more apps coming up, our community was able to learn from each of them to find out where they succeeded, where they struggled, to share case studies, to then make sure that every subsequent app launch went a little bit better. But we weren't seeing that much momentum in the US. And meanwhile, over here, a man named Dan Kahn joined the TCN coalition to get involved. And he said that Linux Foundation was planning to launch a public health project. So seeing as we had the same goals, TCN Coalition merged with the Linux Foundation and became part of the launch of this new organization. And so we were able to bring our culture of communication collaboration into the LF. And with the launch of LFPH also came two new open source apps, COVID Green, which was contributed by Ireland and Nearform, and COVID Shield, which was contributed by Shopify and being used by the Canadian government. And with these two code bases, it meant that any jurisdiction had access to code that was ready to be deployed and that was really already in use in other places. And so with the joining of the Linux Foundation, this gave us the resources to increase the cadence of events, to share best practices, invite more people into the community, engage with public health authorities that we hadn't contacted already. And also we saw another great success, which was APHL launching a key server that anybody could use. What this meant was it removed the need for a state to stand up its own backend server to run an exposure notification system, which further simplified the launch of apps. And so suddenly it was cheaper and easier to launch an app in the US quickly, and we saw the results. New York, Delaware, New Jersey, and Pennsylvania launched within weeks of each other, all on COVID Green with the help of Nearform. New York State especially was exciting. 6 weeks from when they signed the contract to when they had an app in their customers' phones, and it was $700,000, which is not a lot of money as far as developing apps go. So not too long after this, Exposure Notification Express launched, which was a no-code solution with open source servers, also hosted by APHL. And the fall went by in a blur. We saw states launching solutions every week or two, new best practices being shared in our Slack, on the blog, through events. And now you jump to today, we've got 25 states and territories who have a pilot or a fully launched app. We've got tons and tons of apps globally, and they're all interoperable. And it's really an incredible victory. And in such a short time, we really figured out how to move at pandemic speed for this. So there are a couple of lessons that I think we learned from this, right? What are some of the things that we got right? Our values of openness, transparency, and community. So openness, meaning that we had as many things be open source as possible. Documentation, the code, all of these things. We welcomed anyone and everyone, whether they were marketers, technologists, ethicists, researchers. Every single perspective was welcome, and this was because we also valued being open to different perspectives, ideas, and directions. Having that debate in the public was, I think, a real critical part of making sure that there was adoption of this technology. The second piece is transparency. So having the code accessible meant that we could be transparent about what this app was and was not doing. Privacy researchers were able to look and confirm that these apps were really safe to use, that people could download them and be comfortable with it. And it was also then us communicating about what the code could and could not do, both with the public and with public health authorities. And listening to user concerns and addressing them straight on, right? Being transparent about that and being straightforward about that. Not saying that this was going to be a panacea and the silver bullet that could stop the pandemic, but saying that we thought it could help reduce infections by a couple of percentage points, which is exactly what we saw, right? The UK study that just came out showed that for every 1% increase in user adoption of their exposure notification app, they saw somewhere between 0.8 and 2.3% reduction in additional COVID cases. That's a meaningful amount of contribution to the pandemic for an NPI, but not something that's solving all the problems. And we also really focused a lot on community, right? Multiple venues and ways for people to connect, making sure that we were communicating and learning from each other, and keeping in mind our mantra that public health is not a competition. Even if two companies were competitors like Apple and Google, or two vendors competing for a contract from a public health authority to deploy an exposure notification app, we set the standard that they were still expected to contribute to our community, that they were expected to work together to solve common problems, and make sure that we actually managed to see success with what we were doing. The only way that we're going to succeed with exposure notification is if all of us as a community were working together. And so with that, I know it's not a lot of time, but that's a little bit of a story there on how we got to where we are today. I hope that we continue this conversation on the panel, and I look forward to it. Thanks so much.
Hi, I'm Jim Ivey, Chief Operations Officer for Chexout. Chexout is a fully integrated end-to-end solution for public health infectious disease control, working from Hawaii to the U.S. Virgin Islands. Our software is flexible enough to do everything from managing clinics to replacing legacy electronic disease surveillance systems, while also allowing health departments to choose only the features needed to supplement existing systems and phase in new features over time. Chexout had an advantage coming into COVID because we've already had a fully developed contact tracing and patient management solution built specifically for public health infectious disease control. We originally started in HIV STD, so actual contact tracing with DIS and contact tracers wasn't new to us. In March of 2020, Chexout was chosen by the CDC from a field of nearly 50 companies to pilot a national contact tracing program. The program was ultimately stopped by the administration, but it highlighted our expertise in infectious disease control and contact tracing. To combat COVID, we were being tasked with ensuring that multiple critical functions, some existing in our software, some yet to be developed, were rapidly implemented and in many cases, customized for health department requirements. While we already had software developed for public health contact tracing, we learned right from the beginning that normal 2-week sprints for customizations wasn't going to cut it for COVID. Additionally, CDC guidance was rapidly changing and health departments had their own unique needs. We went from 2-week sprints to 3 to 5 day cycles for client request, development, testing, and deployment. Every internal resource was directed to supporting our customers in their COVID responses. We were being asked for capabilities to manage testing locations and provide patient notifications and patient portals, which included clinic management and mass testing event capabilities. We had to collect the information necessary for reporting and the information that is critical to working investigations and understanding what's happening in our communities. We had to have a dynamic patient communications platform that included SMS, email, and VoIP, outbreak management module that could be viewed by outbreak type, by location, by cluster, and identify emerging outbreaks. Provide dynamic cluster diagrams, visualize and interact with investigation data. We integrated isolation monitoring and custom surveys via SMS and email, and flag specific responses or cumulative responses that would trigger tasks for the appropriate staff. And we had to manage data, including multiple in and out flows, which may be one of our most important capabilities. We're data agnostic and can combine data from multiple labs, electronic disease surveillance systems, electronic health records, patient information management systems, and in most formats, including HL7, flat files, CSV, and more. We were surprised to learn how many states had to cobble together incomplete multi-application systems. The last thing public health should be doing during the primary phase of a pandemic is struggling to assemble piecemeal applications that don't easily communicate with each other and have overlapping, conflicting, or gaps in features, and in many cases make it harder to get a full, high-level view of all data at once. This is where having a single solution with integration from the testing site to the contact tracers to symptom monitoring and compatibility with all your data sources becomes critical to a fast, aggressive, and effective response. I'll talk a bit about 4 different use cases for rapid deployment during COVID and what we did to make it all work. The first was whatever you think is fast isn't fast enough and one size doesn't fit all. In May of 2020, West Virginia gave us 30 days to have their solution live with a number of customizations, including integrating with their VoIP system, taking data from their electronic disease surveillance system and combining it with incoming electronic lab reports and patient symptom surveys to automate many functions critical to case investigation and contact tracing. We had to train and coordinate the work of 1,000 contact tracers as they performed all data collection, patient communications, and investigation activities. We continue improving features, and Chexout can load balance against available staff, can logically assign investigations by work group, jurisdiction, or other qualifiers, can open, close, or assign statuses to investigations or close contacts through rules based on the latest CDC guidance, including differences between antibody, antigen, and molecular testing, time between tests, and apply the same information to set custom rules for reactivation or reinfection. Most recently, we included the ability to take vaccination data to help investigators know which individuals to focus on and to help generate data on patients who have been vaccinated and have had COVID or may have been in close contact. And for new features, telehealth and enterprise Wi-Fi proximity tracing are on the way. Our next step with West Virginia is to fully replace their version of the National Electronic Disease Surveillance System, or NBS. The city of Philadelphia uses a custom set of features in Chexout to run their COVID testing vans, including online appointment scheduling, managing the patient encounter, results notification, and post-test educational material delivery. Their vaccination program also uses Chexout for appointment reminders. The U.S. Virgin Islands has been using Chexout for COVID test result delivery at all of their ports of entry. For Indianapolis, which was a 25-day deployment window from our startup meeting, they required a single contact tracing and patient management system that could combine data from their state's Microsoft Dynamics system, electronic lab reports from their local health department, patient symptom surveys, and data coming from the NCAA tournament, which they're presently hosting. They also have the Indy 500 fast approaching. Each event poses unique challenges for contact tracing, patient communications, and reporting, as both bring large numbers of visitors to the city in the form of participants, spectators, and, well, celebrations. Indianapolis, much like West Virginia, will be using Chexout for all conditions in the near future. The goal here is to take lessons learned from COVID and apply them across the board to streamline operations, generate better outcomes and better data through their many areas of responsibility. I think the biggest takeaway from technology during COVID is the need for comprehensive, multifunctional, and data-agnostic solutions that allow each health department to choose the feature set that is best suited for their unique requirements, and most importantly, to get data to where data needs to be when it's needed. Managing infectious disease outbreaks, whether HIV, syphilis, measles, or another coronavirus, requires similar investigative tools and data collection. Maybe COVID truly has caused all of us to rethink and rebuild how we manage any future infectious disease outbreaks and how public health and private industry can work together to prepare for the next and inevitable outbreak. Thank you for your time. We're grateful for the opportunity to present, and I look forward to the panel Q&A.
Hi, I'm Dr. Paul Jarris. I'm the Chief Medical Advisor at the nonprofit MITRE Corporation, former State Health Commissioner in Vermont, and for 10 years I served as the Executive Director of ASTHO. I'm really happy to be here today to talk to you about SARA Alert. SARA Alert's a tool we built with public health for public health. A number of us public health professionals within MITRE recognized the nation did not have a tool at the ready to respond to a pandemic or an outbreak quickly at our borders, so it didn't enter the country, but rather in COVID-19, we found widespread community outbreak. Or even if it began domestically, we didn't have a tool that we could scale to respond to a major outbreak and monitor people who may be coming from areas with infection or other exposure. And also we did not have an efficient way to monitor people in isolation and quarantine in our nation. So we set about to build a system like this. And SARA Alert is a standard-based open source tool, and it automates the process for public health of monitoring individuals who are exposed to or infected, in this case, to COVID-19. But importantly, it is disease agnostic, disease independent, and can be easily configured for other uses. The tool, again, easily configured so it can be stood up day one of future pandemics or monitor our day-to-day outbreaks that we have. We also created a cloud-based tool. This means we can have an instance across the country that we maintain, that we update, and individual jurisdictions don't have to buy their own servers, they don't have to download software, they don't have to maintain the software. We can do all that for them. Now, because this system has personally identifiable information, we had to make sure we had a very secure system. And the architecture for this system was built by people who otherwise work in defense or national security, so it is very secure. We know with the outbreak that we're never quite sure how big it's going to be. And in fact, COVID is much bigger than we ever anticipated. So we built a tool that is scalable and in fact will auto scale and expand to handle the outbreak of a pandemic as it is growing. So the system we have built is an enduring system for our nation that can last and prepare us for any future pandemic as it is now helping us manage COVID-19. So let me tell you a little bit about how the system works. we have two basic flows here. On the top, you can see the flow for people who are sick and in isolation. And on the bottom, you can see the flow for those who are exposed and go into quarantine. This is a tool to help public health do that in an efficient and effective way. So someone who's enrolled, and they can be enrolled through an API, through another system like a Salesforce system, or like in Pennsylvania is doing, or through Maven or RedCap or other systems that you commonly use, or some you can directly enter them into the system. When they are entered, they ask how they'd like to report in on a daily basis. They can report in through text, on the web, through email, or phone calls, and very importantly, SARA Alert can reach out to landlines. So it's being used, for example, in Montana, which has frontier locations, in some of the Native American reservations, and other areas, again, where people may be beyond broadband, beyond cell phone use. We wanted to make sure it was inclusive, and we crossed that digital divide and made it available to everyone. If you look at the bottom where someone's in quarantine, probably 50 to 75% of people will never develop symptoms. In that case, SARA Alert pings them every day. They respond they don't have a symptom. It thanks them, and it continues that throughout the course of the quarantine. It then will release the person from the system. That means public health didn't use their scarce resources to reach out to people who otherwise were okay and didn't need that reach out. Instead, they can reach out to the people who have a symptom or are not responding to find out why they're not responding. So very importantly, as soon as that symptom comes in, it goes in the line list where an epi or public health nurse can reach out, confirm the symptoms, get testing done, get clinical care provided, and then the person can be safely managed. Likewise, above in the isolation, when somebody meets that recovery definition, public health can reach out to them to confirm that they've recovered and safely return into the community. So it enables public health to handle much larger workloads, reach out to people who really need to be reached out, target their interventions, keep individuals safe as soon as they develop symptoms, keep community safe so people don't go out until they're recovered. So that's how the system works. Much more detail if you'd like to attend a demo or another setting. So again, as I mentioned before, we were very carefully in how we built this system to make sure that we involve public health at every step of the way, and that we had that eye toward what is such a unique public health responsibility, those who are underserved. In the beginning, again, we checked out this consult with public health leaders across ASTHO and NACHO and CSTE, APHL and public health and CDC and others. And they said, great idea. If you can build this tool, we've never had it. So we locked ourselves in a room, public health people with engineers, whiteboarded out the process for managing someone in isolation quarantine, and the engineers started coding. Within 10 days, they had a prototype. We went to CDC, we went to state and local users, and we said, here's our prototype, break it. See what you can teach us about what we did. It was prototyped, and then within 10 weeks, we actually had a pilot. We stood up in the Commonwealth of Northern Mariana Islands and in Arkansas and started the use. We learned a lot from that. In fact, in Arkansas, they recommended that we build the isolation flow for the people who were sick. So we built that. We learned from other jurisdictions they needed different languages. We learned of fixes. And what we're doing on a continual basis is we're doing something what they call Agile Development. We've released over 26 different iterations of this, where at every step of the way, public health comes to us and says, here's what we'd like to see, here's how to make this better, here's some bugs we want fixed. The engineers make the changes. They're then tested by the public health community, and when they're happy with it, it's released. 2 weeks later, we come back, we do it again. So every step of the way we've involved with public health. You'll see a green circle around here that says Senior Leader Steering Group. The CEOs of ASTHO and NACHO and APHL and CSTE, the CDC Foundation, with CDC participation are our steering group. We meet every other week. They guide us. They let us know what's going on in the field. They recommend the direction we should take so that this does, in fact, become a sustainable tool. Very important to that is the governance. We're looking at different governance models and what we call collaborative governance, where the stakeholders will come together and decide how SARA Alert works in the future, what the use cases are, and the other issues, so that, in fact, it is public health owning it, as this was built by public health for public health. So how are we doing? We've been very gratified. Right now, the jurisdictions that are utilizing SARA Alert serve populations of over 40 million Americans. This is in 1 year's time. We've monitored over 2.5 million monitorees in the system who have been in case contacts or sick throughout that. And as you can see, we're working with states, we're working with tribes, we're working with territories, we're working with freely associated states, over 400 local jurisdictions, and we're actually working with independent industry, academia, and others so they can take this open source tool and configure to their needs. At this point, the outbreak has stabilized down about 150,000 people a day in the system. We've been way over 200,000 at higher points in the peak. We hope this tamps down the outbreak. So to summarize, SARA Alert is an open source, standards-based tool that is hosted on the APHL AIMS cloud. It is available without charge to any governmental public health jurisdiction, and will even come in and help you set it up, train your folks, and get the thing going. So it's a real pleasure to really speak to you today. I look forward to your questions, and I'd really look forward to working with you to implement a very effective tool, SARA Alert. Thank you.
Thank you so much to our panelists for those sessions. And I know that we have the Q&A feature enabled for those to chat questions in. So for any audience members who do have those questions, please feel free to start populating that and submitting those. We do have a question to start that I'd like to pose to our panelists. And again, I really appreciate how each of you delved into how you work with stakeholders, what various tools or platforms you used, and what challenges you faced. So really the first question that I have to pose to you all, just to get us started, is, as each of your organizations were planning, developing, and piloting these solutions, how did you go about determining those needs and those gaps with public health agencies as you were doing this? And especially given the context that so much of this work is very new to public health. So much of exploring and testing these solutions is very new, and some of them are learning along with you what works and what doesn't. So yes, if we could start out with how did you determine those needs, identify those gaps in concert with public health, that would be great.
I'm happy to go. We basically knew about this for a long time because we had a group of EPIs and public health people come together who were very experienced in the field. I go back to the original SARS outbreak. We have people that have worked on Ebola, and we've known over time that we didn't have the tools we need. So it was more an issue of how do we develop a tool we've known for over a decade that we need. And so what we did is we locked ourselves in the room with the engineers. We brought in NACHO, local health officials, and others to sit down and talk about, how do we design this? So yeah, the need was there a long time. We actually began this work before COVID-19. And COVID-19 was one of those crises we didn't want to waste, although it turns out we never knew how big it was going to be.
Thank you for that.
I'd be happy to jump in next. So the working with our public health partners has been a long process for us as we started in STD. So we were able to take those same best practices around contact tracing, and then we would, when we start a project, we have to look for all the different data sources. Where are legacy systems that don't communicate, and then how can we build custom workflows around some of the existing limitations when we bring in a greater feature set overall. So it's a collaborative process that thankfully we had some experience with from all of our years doing contact tracing and STD.
Yeah, and I think our approach was actually a little bit different. Back to that idea of having an open community, is that we actually brought the public health authorities together to talk with each other. So rather than being sort of a node and doing a lot of one-on-one conversations, right? In July, we hosted a symposium with 150 public health officials and technologists together that included both presentations as well as working sessions so that people could actually have these conversations. Since then we've continued with regular events, and forums in which to have those conversations. We've got a Slack channel where people are actively, constantly putting in, hey, I'm seeing this problem. Does anybody else have this? So having just a number of different forums and venues and ways for public health authorities to work with each other to solve these problems rather than, and to then highlight and bubble up the biggest of them to try and get our staff and get, and communicate out to the right people to get those to be solved. So I think that was really our approach for getting the public health authorities involved and getting their input.
Thank you all for really providing that context and setting the stage for your work and engagement with public health. And with that said, we have gotten a number of audience-based questions here today, and some of them are specific to some of our panelists. So I'll address them and kind of go by order. Again, keep the questions coming for participants who joined us. So for the first one, this is directed, Paul, to you and into the work that you all have done with SareAlert. How can SareAlert be used in other diagnoses and diseases of public health significance? Are there other instances, or can the same tool work to monitor more things at once? So another pandemic
right.
with COVID.
It's a great question. One of the things we learned in Ebola, there were 2 states, Maryland and Georgia, that built an Ebola tool. And now comes COVID-19, can't be used, it's on the shelf. So we built SareAlert. It's actually engineered to be agnostic to the condition. So we can rapidly change the database and stand it up for another condition. Right now, we're standing it up for Ebola because we're monitoring people coming into the country from 2 of the African nations. So it will eventually be all cloud-based, and we can stand up multiple, the measles, the mumps, rubella, whatever we're dealing with, as well as a pandemic or anything else. So what we didn't want to do is to have multiple different systems that public health would have to log into multiple different ways, or have a one and done, which we've had in so many of our public health systems in the past.
Thank you for that. All right. The next question that we have here is for Jim with Chexout. So this is from someone who works at a local health department, and they'd like to know a little bit more about your security features. Are there available features to only allow one patient, for example, to register for clinics, and restrictions around preventing sharing of clinic registration?
Yes. So the data security is probably the most important thing that we do. And all of our practices meet or exceed all state and federal regulations for protection of personally identifiable health information, including the CDC's data security and confidentiality guidelines. Beyond that, we use a system of role-based access and different tools to make sure that we are protecting patient confidentiality, whether that be within an STD clinic or if that's with COVID, so that we make sure only the individuals who are supposed to be accessing that information can access it. So there are a lot of guardrails around how we allow our customers to customize access.
Appreciate that. All right, and then another one that we have here, and this is for all of our panelists, so I encourage you all to think about, especially more broadly, how you'll answer this, and perhaps we can start with Jenny first. But how many functional tools does it take to manage a pandemic? Can a local health department or even a state health department manage this way in the next public health emergency? So I think this kind of gets at some of the gaps and challenges that each of you mentioned. So if you could take a moment to answer really that question of how many functional tools does it take? Are we expected to manage this way in the future?
So I wish I could say very clearly, oh, well, if you have 8 tools, then that's all you need. Unfortunately, I don't have the answer of exactly how many tools it takes, but your sentiment is totally correct, right? This pandemic, there was an overwhelming number of tools that came on the market all at the same time to help manage the pandemic. And every single public health authority I talked to mentioned being overwhelmed by vendor pitches. That was both consuming up a lot of their time as well as just their inboxes, right? Even if they weren't taking the meetings. And especially considering the massive decline in funding that public health authorities have been getting over the past decade, it's absolutely unreasonable to expect every LPHA to manage all of these different tools to figure out which ones are good and quality, which ones are worth their money, and to actually go from there. And so I think that's where, that's a lot of actually our mission, right? Is to help solve that problem. We want to find ways for there to be open source software that's easy to deploy, that starts to complete your tech stack in such a way that you don't have to go through that selection process in the same way. And so that you don't have to be managing all these separate tools, but rather that it's a little bit more packaged and easier to work with. How we get there, it's going to be a process, right? And preparing for the next pandemic, that's going to be on all of our minds for a long time. But I think that the current system, I think the current system with all of the flexibility that it gives to the LPHAs, while that's fantastic, it also creates these enormous challenges on the IT infrastructure side. And so I think that that's going to be one of the conversations that we're going to be having for the next several years of how do we make it so that LPHAs don't have to manage all of their IT, but can still have the flexibility that is desired in order to be able to serve their communities best.
Thank you for that. Paul, if you feel compelled to answer
Yeah,
this.
sure. So what we made sure we built a tool that could be used at the state, the local, the tribal, and the territorial area, because we knew the resources are vastly different. What that means, a cloud-based tool that the public health users and engineers modify as collectively as a group, so that the local health department or tribal health department or the territories don't have to buy software. They don't have to stand up their own servers. They don't have to monitor, maintain the software themselves. And then in addition to that, the tool is built so that for a smaller jurisdiction, they can just use SARA Alert alone to monitor the isolation, contact tracing, quarantine. But it's built also to be interoperable. So for jurisdictions that have more tools, whether that's Salesforce or where we're interoperable with Salesforce for API in Pennsylvania, or whether it's Maven or RedCap or NBS, that information can be exchanged with SARA Alert and then reloaded up into SARA Alert after that active monitoring is done. So we try, again, very conscious about making sure that we could serve those with the least amount of resources, or in this case, the greatest amount through the interoperability. We think it can meet the needs of anyone small to big jurisdictions. And we have some very small frontier health departments with very few staff that are using it. And prior to having a tool that was this efficient, they simply couldn't do the contact tracing and the monitoring.
And Paul, I just want, I think that that's a great point that you make about it, how much of your platform is open, and how that does enable that interoperability, and that does make it so that it can scale and it can serve so many different needs of so many different public health authorities. It's one of the things that I've been loving about.
Right, and as an open source tool, we've also worked with proprietary vendors to build it into their proprietary software, because that still means it gets it out there, because we're operating under a CDC grant. So this tool is available free of charge to any public health jurisdiction. And so we're not selling anything. We just want to partner and get it out there so that people have what they need.
Jim, anything you'd like to add to this question?
Thank you. I think interoperability is really key here, because when you ask how many tools should we use, I think the answer is all of them. The biggest problem, though, is trying to manage all these disparate systems and then have that interoperability and the ability to communicate between them so that we don't have information siloed off and unusable. I think the biggest thing is what's been discussed is finding software systems that can utilize all of these different tools and bring it together in a way that's usable by the contact tracers in the field, right? Because our end users, the actual contact tracers, the ones that we have to tailor the software tools to, so that it's really usable and helpful.
Really appreciate that answer from all of you. Really, really comprehensive and thoughtful in that way. And I think and we have time for one more question. So I know there's a couple that have come through, but I'll go ahead and ask this last question here, since it's a big one. And if we do have time, based on the answers, we might have time for another one, but we'll try to squeeze this one in. So to segue from, working, with many tools or navigating that piece, this question is around what are the key lessons learned from your efforts that should be supported or expanded upon for health, human services, systems transformation for modernization across multiple sectors within the spectrum, public health, healthcare, behavioral health. And so that's the first kind of part of this, is how should these lessons be learned, or how should these lessons learned be used for modernization? And then are there ideas about how states can leverage the additional funding and resourcing to support continued modernization?
Sure. I think one of the biggest lessons that we learned is that the most efficient and effective way to combat a pandemic is to have all of your tool sets together, right? So coming down from the surveillance system to the data collection, to the symptom monitoring, to even running testing locations should all be interoperable and packaged together in a way that that information moves in real time, and then can do things like accurately power state dashboards, or keeping schools open based on infection rates. So I think however it comes together, that you bring all of your software pieces, it needs to be a single stack that you don't have any pieces that are fighting each other and conflicting.
I would say that for us, and there's so many lessons, but we've been really guided by the DMI, the Digital Modernization Initiative guidance, and we've been using that all along, because in fact, we will be turning this tool over to public health to run. We're research and development company, so we're going to turn it over, but open source, standards-based, getting public health involved day one, where the actual users are directing the building of the tool. Also building a tool that is interoperable, but also has reusable components. So it's not built for a specific use case. It's built to be in a way that it can be reused for multiple use cases. Whether those are the peacetime use cases, the measles, mumps, rubella, even environmental exposures. That way people would continue to be trained on it and how to use it. And then it can quickly be adapted for an emergency outbreak, because those will happen, but they may only happen every few years. So it's difficult to pay for a tool to be maintained to be used every few years. So there's so many lessons here, and we're hoping that by working with CDC, we're building this in a way that is an example of how data modernization should progress.
So Valerie, this question could be an entire session in and of itself, maybe several. But yeah, Paul, I agree with you, right? We learned a lot this time around about the power of open source, about open communication, all of that. I think as we look towards the work we're doing now in vaccination credentials and thinking ahead with those coming down the line, how we get that to see some of the same success that we've seen with the technologies that have been deployed so far. One of the things that we are talking about with HHS is the importance of federal leadership, making sure, not necessarily publishing the app themselves, but making sure that they are being very clear and transparent about where their intentions lie. One of the things we saw with exposure notification at the beginning was a lot of states saying, well, I'm going to wait till I hear guidance from the federal government before making any decisions myself, because I don't want to duplicate work. We saw various challenges with it being deployed state by state, each with their own technology. The more federal leadership we have on this, where it's even just saying, here's an open source code base that you can use that's developed to meet the basic needs, and then you can go from there. That kind of resourcing of technology goes a long way to helping state and local public health authorities actually adopt this technology and move forward with it. I think also, one of the things that we are seeing, I think that has been mentioned both in the keynotes and in this conversation, is the challenges related to grant-based funding. I think that that's made it, that when COVID hit, it became very apparent how many of our systems couldn't be adapted to COVID. And the way in which everything was built and the proprietary nature of so many pieces of our infrastructure meant that it was hard to get the vendors to adjust things as well. So even with the funding, because of the way it had been built originally and the original mandate, there were all of these tangles and all of these things were very hard for us to navigate around. So I think that those are a couple of the highlights. And yeah, clearly we need to have a much longer conversation about this.
So that's a very nice segue, Jenny. Thank you so much. And again, I want to thank all of our participants for joining this afternoon, participating in the Texpo today. There are some notes that will be made available in the chat in terms of how to evaluate today's session. If there are questions that you had, we also encourage you to submit those through that piece as well. And all sessions from today's event will be available on the platform over the next month. So there will be more opportunities for you to access that information and potentially reach out with additional questions. But if you, just to wrap things up, as we kick it off into the next coming events, if each of you could just say a one-liner of what you would like the audience to take away today based on the work that you've done. And we'll start with Jenny first.
Yeah, I think I'd stick with what I said before, the importance of openness, transparency, collaboration.
I'd say that the most important takeaway I could come up with today is that it's critical to have all of your systems combined and working together, from the contact tracers in the field through symptom monitoring, through data collection, all the way through surveillance. So I find that to be critical.
And Paul?
Yeah, I'd say, we're all exhausted. And the tendency is, when a pandemic is over, to forget about it, shutter the fire station, sell the fire trucks. I think we need to make sure that we continue to build an enduring system for our nation that we can stand up day one, so we don't again learn about widespread community outbreak as the first notice that it's in this country. So that open source interoperability, but making sure that we have reusable platforms that we can use in peacetime and in pandemics.
Absolutely. Well, thank you again to our panelists. Each of you were wonderful. And thank you to our participants for participating today, submitting your questions, and look forward to seeing you all at the next sessions.
Thank you.
That's good. Thanks.